Our next speaker is Dr. Himanshu Pandey from India. He's going to talk on is combined PARP inhibition in castrate-resistant prostate cancer a new standard. Over to you, sir.
Very good morning to esteemed chairperson and August gathering. At the outset, I would like to thank Sri Lankan Association and SAC Association of Urologists for providing me the opportunity. So my topic, which I have been asked to speak on, is combined. Although I am an urologist, it's a more of medical oncological topic, but despite being a urologist, we must know the medical management of the metastatic and advanced prostate cancer. So my topic is combined PARP inhibition in CRPC is going to be a new standard. So as we know that around 1.3 million new cases per year worldwide are detected with prostate cancer, and with increasing use of biomarkers for screening, detection and prognosis, we are able to personalize the approach for treatment while minimizing the intervention in localized and indolent cancer, and on the one hand, and on the other hand, escalating the treatment in very aggressive tumors or the tumors who are at high risk of relapse or metastasis. So what are the genomic alterations where these PARP inhibitors they act? So normally the normal prostate epithelium, it progresses to prostatic intraepithelial neoplasia, and then there are DNA compromised DNA repair mechanisms which lead to localized prostate cancer and then to metastatic, and followed by castrate-resistant prostate cancer. So there are multiple compromised DNA repair mechanisms. So two of them is mismatch repair, and the other is the homologous recombinant repair gene. So the most important is for the double-stranded DNA repair pathway is the homologous recombination repair, and for single-stranded is mismatch, where both of these are mainly targeted for the management of castrate-resistant prostate cancer. So around 23% of the patients with metastatic CRPC, they are detected with the DNA repair mutations in single allele or the biallele. So they are tested through germline testing or the somatic testing. Ideally, both the somatic and the germline testing should be done to detect it completely, but somatic testing is quite expensive, and germline testing, it misses almost 50% of the patients who would be eligible for the PARP inhibitor. So based on the initial trials and results, FDA approves the PARP inhibitors as the monotherapy, which are the olaparib and the rucaparib, and the patients who experienced the progression following prior treatment with enzalutamide or abiraterone or docetaxel. So this was the initial point where the PARP inhibitors were approved by the FDA, and later on it was thought that why not to combine these PARP inhibitors along with the AR or the immunotherapies. The rationale behind was that the many patients who progress on castrate after castration and even on abiraterone and enzalutamide, almost 40% of the patients they drop out for further treatment, and this is a significant number of the patients who can be managed, with their quality of life can be better. So the multiple trials they were started and they are underway. So blue ones are the phase 3 trial. This is the PROPEL, which combined the olaparib with the abiraterone. The talazoparib, that is the TALAPRO trial, it combined the talazoparib with the enzalutamide, and the rucaparib was combined with the enzalutamide, and the niraparib was combined with the abiraterone with the magnitude trial. Other trials are still in the phase 1 trial. So there were three main phase 3 trials which combined the PARP inhibitors with the AR. One is the BRCAWay, which actually didn't, where the abiraterone was combined with the PARP inhibitors, but olaparib, but it didn't reach the primary endpoint, that is the radiographic progression-free survival. While phase 3 PROPEL and magnitude trial, they reached to their primary endpoint, that is that they showed that radiographic progression-free survival was achieved in a significant number of patients. So magnitude trial, it used the niraparib with the abiraterone, and the PROPEL trial used the olaparib with the abiraterone and the prednisolone. So survival outcomes, although in the initial phases it was not reached to the expected level, but it imparted a huge implication in clinical practice. It was said that in magnitude trial that we should await the overall survival data and plan biomarker analysis for BRCA versus non-BRCA mutations. And they also said that it may be reasonable to use the BRCA mutation patients presently with the niraparib, given the poor outcomes with the abiraterone alone. While the PROPEL trial, it showed that improvement in the radiographic progression-free survival is very significant, but they also said that it need better understanding to which patients is to be applied for. Then came the TALAPRO-2 trial, which used the talazoparib along with the enzalutamide, and there was another trial, that is the phase 3 CASPER trial, which used the rucaparib with the enzalutamide. And both of these trials, they met their primary endpoint, that is the radiographic progression-free survival. So following, based on these various trials, the FDA recently in the first half of this year approved this olaparib along with the abiraterone, talazoparib with enzalutamide, and recently the niraparib with abiraterone in August 2023. And to be noted that these approval is for the metastatic CRPC with the DDR alterations, means the mutational only. So now we are moving with the encouraging results of these trials with, for these mutational patients, where PARP inhibitor in combination with AR have shown good results. So now it is being thought, but is there any place for the combination of AR and PARP inhibitors in earlier disease? So the various trials are underway, mainly is the TALAPRO-3 trial, and the results are to be waited. So to conclude, PARP inhibitors along with the androgen receptor targeted therapies, they may become a new effective treatment approach in patients with the homologous recombination repair deficient metastatic CRPC. Although the biggest controversy is still there whether we should use them in combination with AR targeted agents with respect to the overall survival, because still we do not have the overall survival data, because the trials, majority of the trials are with their interim results after 2 or 3 years of the follow-up. Second, should we use the combination upfront for all, regardless of their mutational status, or should we use them in a select patient population? So these are the controversies which need to be answered in the currently ongoing trial. Thank you very much.